Hello again. This time we're going to go through the chapter on chronic throat pain and chronic cough. So, this is a common complaint. A lot of people have chronic pain in their throat, and since it can be associated with acid reflux, I would see a number of these patients. And you could say the same thing about chronic cough. Chronic cough, a lot of times, will be from acid reflux, whether the patient is standing or lying down. Some people have more problem when they're lying down and with acid reflux, and some can also have problems when they're standing up. Um, so a number of patients, though, will not have your classic acid reflux heartburn symptoms. So it can be difficult to know for sure what is going on without doing further diagnostic testing. Now, as far as cough concerns, a common condition that used to be called postnasal drainage occurred with people that had a lot of sinus drainage in the back of their throat, and that can trigger cough in some people. But there's a new term out now called upper airway cough syndrome that is being used to replace postnasal drainage. But the implication there is that you have some increased sensitivity in your cough reflex to drainage in the back of your throat or other irritants that are occurring in your throat causing you to cough. So, as I've previously mentioned, it's important to think right off the bat what medications the patient is on. Certainly, if you're on an ACE inhibitor, this is a common cause for coughing. And if you can relate that to when you started the medication, then that becomes even more proof. But most of the time, it has to be changed. And when it's changed, the problem typically will resolve. Usually, I would have to call the provider. I can't leave it up to the patient to accomplish this. So when I contact the provider, usually then it'll get changed. I did have a personal experience with Singulair, and if you look up Singulair, you'll notice that it can cause a cough. So there's certain medications that can trigger cough that are uncommon to do so, but can occur. So that's always important to keep in mind. Now, when it comes to trying to diagnose patients with chronic cough or chronic sore throat, and sometimes other associated symptoms such as asthma cough, then diagnostic tests may be helpful. And so the gold standard for acid reflux testing is to prove that there is excess acid exposure in the esophagus. This is known as a 24-hour pH probe study. Now, this can be accomplished with the help of upper endoscopy. And upper endoscopy really is a helpful tool to diagnose whether this patient has acid reflux or not. The upper endoscopy can be normal, and the patient can still have acid reflux. And a lot of times, what's recommended is a trial of medication. And usually that trial of medication is going to be the more powerful acid suppressive drugs, such as Prilosec or Nexium. These types of medication are more potent acid suppressors than drugs like Zantac or Pepcid. And so there's a certain regimen that may be chosen to see if there's a good response of the patient, and it would imply acid reflux. The disadvantage of not doing upper endoscopy is that there may be lining changes known as Barrett's esophagus with chronic acid reflux, or acid reflux erosions, or even scar tissue and stricture, you may not be aware of unless you do upper endoscopy, or also known as EGD, esophageal gastro duodenoscopy. This typically, in today's practice, requires some sedation, although in the future it may not require sedation. And it may be also accomplished with the use of a smart pill, or a pill that can visualize the esophagus. These devices will probably be readily available in the future and near future. So at this point, I'm going to go on to chest pain. And I've talked about chest pain before briefly and mentioned that most things in medicine, like everything else, come down to the details. So there's going to be questions having to do with how long have you had the chest pain, where does it radiate, what does it feel like, and so forth. And I've discussed that already. And there's a lot of detail in the book that I put together about this. But chest pain can be coronary, and more commonly it's chest pressure or pressure discomfort. It can feel like no pain in the chest, but more pain in the teeth or in the left arm or even the right arm, or in the epigastrium, in other words, the upper part of the abdomen. But a common cause of chest pain is also acid reflux. So non-cardiac chest pain is thought of mostly as acid reflux. There can be other causes, certainly. There can also be musculoskeletal chest pain, where you have a very well localized pain that's reproducible on palpation. You touch one particular spot and it reproduces the pain. Well, that's not coronary pain, that's musculoskeletal. Now, yes, you can get that from a fracture of a rib or other disorders. Whereas coronary pain is non-localizing. You can't point to it with one finger. It's vague, pressure-like, oftentimes not described as actual pain. So it can be deceiving. And then beyond all of those issues is psychological causes of chest pain. You can get chest pain from anxiety, panic attacks, and such. And so that's also a possibility, and usually saved for last in terms of workup. You can't find anything else, and then you start to ask about feelings of impending doom and other symptoms of panic attack. And also you have to remember that patients can have more than one thing going on. And typically they could have acid reflux and also heart disease and panic attacks all rolled into one. And you'll need to go through those different symptoms and try to dissect them out and separate them out so you have a better understanding of what you're dealing with. I'm going to pause for a moment here.